So, slideshow. Okay. And right. Okay. I think we're okay now. Is that right?
Yeah, it looks great. We can see it.
Yep.
Yeah, it's fine.
You can hear me. It's all right, because I can't see you. Does actually show some of you on the screen, so that's good. Right.
You're breaking up, Paul.
I'm breaking up. Oh gosh. Okay.
Yeah,
I'm sorry about that.
No, it's fine.
Am I okay?
Yep,
right.
Nice and clear now.
Yeah.
All right, thank you. So introductions, well, I guess you can see that where I'm based, and I'm very aware of precious time now. So in terms of what we're focusing on today, I wanted to be about the lived experience of psychosis, particularly focusing on voices, and you know, I suppose finding out about CFT and how you can work with this diverse client group. Also, I suppose in terms of the presentation, I've got definitely more slides than I'll use now because of losing a little bit of time there, and probably more than I would have had anyway. So it's a good place to signpost you to further reading and resources. Okay, so I suppose in terms of where I'm going with this at the moment, that the content will just touch very peripherally on trauma, but I'm aware that there's some people in the meeting who may experience voices. So if there are any issues, you know, do take care of yourself, and also you can contact me after the meeting if you want to talk about anything that's been triggered, anything like that. So it's a really important issue to look after yourselves in this meeting. Okay, but as I say, it's lunchtime. Those of you might have heard that earlier on. So please do munch away as you need, and we'll begin. Okay, so first thing I really want to do is find out, could I have a show of hands, please, about who's had experience of working with CFT? Okay, so Sally, yeah. Okay, and 4 others, 5 others. Okay, so quite a lot of you actually have had experience. That's great. Okay, so, and what about working with voices? How many people have had experience of working with people who hear voices? Okay, so I can see quite a few of you again. Okay, fantastic. Okay, it gives me a good idea of the range. And how many people do we have all together in the meeting? Because I'm just trying to work out what the proportion is there. Could Natalie just tell me how many people we've got?
29, Paul.
Okay,
29.
brilliant. Okay, that's great. Gives me a rough idea. So about a quarter have had experience, very roughly, of working with psychosis, a quarter CFT. Okay, that's brilliant. Thank you so much. And with psychosis, oh, my screen is frozen. Psychosis, right, there we are. Okay, so using the term psychosis quite liberally, aware that it's a contested area. So I was going to ask you about which diagnoses might fall under the category of psychosis, but I think many of you here know about this from, you know, even possibly undergraduate study. You'll know about that. But I would say that in secondary care, one of the probably the important things to understand is that there's a negative valence to voices that brings people into our services. So they may well experience persecution. They may well find that the experience of voice hearing is aversive and at best. Okay. So there's a whole area that we could get into in this talk, which we're probably not going to have a huge amount of time for, but I'm very keen to have questions at the end. So maybe for the last 10 to 15 minutes, we'll have some discussion. Okay, we can come back to some of those issues. But it's kind of really interesting, I find, in working with psychosis throughout my career, about how society's experiences can affect the perception of threat. Okay, they often do reflect the dominant discourses in cultures. So very often finding that people will talk about fear of being exposed as a paedophile and things like that. There's all sorts of different issues which can come up. Okay, so trauma is connected to psychosis, something which I guess many people who've worked in the field will know that there's a very great likelihood that people will have experienced trauma, but it's not altogether the case. And some people who hear voices, the voice may be providing a protective function, and that means that we can't always, if you like, extrapolate from one experience and assume that is actually really linked directly to their psychosis. There may be a sort of a chain of events, a chain of connections that occurs. Okay, so we will find though that in studies that people with first episode psychosis, I work into first episode psychosis service in early intervention in Derby, and we have people on the call here who work in the at-risk mental state service. So those people will find that they, you can read off the screen there that there's a sort of multiplication effect, really. These findings originally were met with skepticism in services, but the emerging evidence has always continued to support this. So when I was preparing this presentation, we were sort of looking at over 350 publications demonstrated a link between trauma and the increased likelihood of developing psychosis. Okay, so childhood abuse would increase the likelihood in this way. Okay, so it's often like a dose response relationship. Okay, so five lots of traumas might make it 193 times more likely. So that seems relatively convincing, but of course this is correlational, and we're still looking to understand about the impact. And stress vulnerability is in there, and that suggests that we all have a vulnerability to psychosis and hearing voices. So if something exceeds what our biological apparatus can cope with, then it's quite likely that we will experience dissociation, and in certain situations dissociation can then link to psychosis. Okay, so Amy Hardy, who worked in London, has written some great stuff about the links between trauma and psychosis. So I'd really, encourage you to read her work. So you can see there that childhood sexual abuse is more commonly linked with voices. Sometimes when people are in touch with the full reality of what they've experienced, then we see that as a dissociative process with impaired reality testing, you might say, or a difficulty making those links back, loss of awareness that can happen with psychosis. Then you can find that the links with voices, aren't so obvious to the voice hearer, but they can be more obvious to us when we're making formulations about this. Emotional abuse and neglect, more commonly related to paranoia. Okay, and you can see those links with previous, pre-psychotic beliefs, okay, about the self and others. All right, so in CFT we have 3 circles, which so many people will be aware of, and these, things sort of deliberately drawn up in this way because the soothing system can be something which hasn't received as much attention in early attachments experiences as other areas. And you can see this issue where you've got the threat system very much activated. You can see there, that it can be, the sympathetic nervous system's involved with that, and the parasympathetic nervous system ordinarily would dampen down threats, so deal with adrenaline and cortisol that's been stimulated, and serotonin has quite an important role in that as well. Sometimes if things have become very overwhelming, then the parasympathetic system kicks in, and then people end up having a freeze response, playing dead. You see in some situations with mammals and even with humans that people, when they're terrified, will curl up and feign death. So the drive system, people, many of you will be familiar with this. Okay. All right, and the soothing system. Okay. So the threat system is very much linked to others. Other people can be threatening, and some of you will be aware of the social graces, that there are a number of different things which can colour how people experience threat. So anyway, in terms of explaining systems with reference to voices, I suppose what we're hoping is that by providing more soothing, and we'll see this on the next slide, that compassion for self, when this is underdeveloped, that we boost this. This is one of the first things that we would be looking for with CFT, with voices, that what we would be doing is to help people to ground themselves, familiar to other work with trauma, but we're actually really helping people to feel strong and confident in their body. Maybe we're doing quite a lot of work on posture and tone of voice and things like that. Okay, so yeah, just trying to sort of widen that soothing circle in CFT terms. Okay, some people can actually feel when they engage with this kind of work a sense of grief and sadness about not having had that developed earlier on, or not feeling that they deserve it, things like that. And it's kind of important, probably, in terms of doing this work, quite a lot of the session, focusing on how to, that we would be looking at people who are providing therapy to have some experience of doing some of the techniques themselves. So soothing rhythm breathing, and working on various aspects of developing compassionate imagery, all sorts of things like that that can help. Okay, so the reference there, Colts, that is in the chat in the PowerPoint presentation. So Russell Colts developed a book, CFT from the Inside Out, and I deliberately sort of didn't use a blur background so I could show you the book. Okay, that's something which I'd really recommend, that as a therapist, it can really get you into the whole process, and working through that is something which it would be excellent, for you as a therapist. In the future, we're hoping to have some introductory training, and some people have already applied for that, also advanced training, and we're keen that people buy the book, maybe at a reduced price, and work on their experiences of CFT. Okay, a bit of self-help. All right, so the effects of trauma and victimization. So of course, we expect these things, but I suppose one of the things that differentiates people who hear voices is that there's high threat activation coupled with a low threat regulatory, low soothing, so high threat and low soothing going together, that the person may be dissociated from their usual self, and this sort of combination means that there's a greater likelihood of people ending up needing to monitor for threats. So we see this a lot. Hypervigilance is a key mechanism when people have been physically harmed. That could include, of course, sexual abuse, and hypervigilance can also be in place when there's social status threats. So this is all signaled by shame. So many of you who are acquainted with CFT will understand that it's a really good therapy for shame and humiliation, and we can really get into some of those experiences in terms of the relational way that we work in CFT. So I hope that point is made reasonably clearly. I'm just aware that the voice content could be very normal, and the majority of people who hear voices don't end up in our clinical settings. They have maybe positive experiences of a comforting voice. They may hear the voice of somebody who they've lost through death or what have you. So it's, you know, it's a really common experience. I think 40% of people in a Swedish study hear they're bereaved. Yeah. So just to talk about, you know, the effects of trauma and victimization is, you know, it is affecting not just your relationship with yourself, but also relationship with others. Okay. And I'll move on from this slide just so we're of time. Yeah. Okay. So I was keen to show this video, which pulls together a lot of the information on this. So I'm just going to temporarily see if I could bring this up actually to the chat. Okay, so I'm still sharing that screen. Can you see this?
We can't see the video running, Paul, but we can see the link.
Can you see this video? Just now?
No.
No, it's not playing, Paul, at all.
I think you might have to come out of the presentation and then like start resharing again, potentially, when you're on the like reshare to play the video.
So can you see this video I'm asking? Sorry.
No.
Oh no,
can't,
oh gosh,
Paul.
okay.
I think you have to stop sharing and then start
yeah.
sharing again and just share the video.
Okay.
Yeah, it's tricky.
Okay, sorry about this. Yeah.
Paul, also in the top right-hand corner,
Right,
you need
sorry
to
about
share
this.
the audio.
Okay. Yep. Okay now.
Yeah, that's it, Paul. We can
There's
see
no
it.
sound though.
Thank you.
There's no sound, Paul.
Paul, you'll need to come out of sharing it, reshare it, but in the top right-hand corner, there'll be a tab share audio as well. So share and then click on the tab in the top right-hand corner.
Okay, you can hear that now? Yeah.
It's not playing now, Paul.
I'm sorry about this.
It's not
Yeah.
playing.
Okay.
No, it's fine. Absolutely fine. It happens.
It's confusing for me here. Okay, Lisa, you've got your hand up. Sorry.
Sorry, I don't know how to put my hand down. I'm not very technical, I'm afraid.
You just click the same button again. There you go. Yeah.
Oh, thank you.
Right, sorry about that. Oh dear. Right. Okay. Right. Just need to reshare. So sorry. We had some technical problems when I did Bitesize training before. Oh no. Sorry guys. Right.
Well, if this is a problem, we could maybe just copy and paste into our own browsers and watch it and come back to you.
Yes, I guess. Yeah. Just bear with me now. Slide. Right, that's better. Okay, so I'll just bear with me again. So yeah, I mean, people can come back to that video themselves. I mean, I'd really recommend it because it's something which brings together all the aspects of CFT. You can use that with service users really effectively and so forth. Okay, so just moving on. So how it works, I mean, really what we're looking at here is helping people to switch to a different social mentality. So from threat to caring. Sorry, I just need to swap. That's better, yeah. Okay, so in terms of this process, that we recognize that people are in threat, and that threat circle's got very big, and we want to help them to move to the caring side. Sometimes people have recommended distraction for voices, and of course distraction has its place, and engaging with the drive system can be useful. You know, I think we all get into activities which are really beneficial for dealing with threats in one way or another, and the experience of generating warmth and safety is sometimes quite a controversial one for people who have been used to having quite a what's the word, you know, sort of, you know, dealing with hostile competition and so forth. So it's something which we need to help people to find relevant to their lives, and fear of compassion is something that we often come across, and we even have a questionnaire which can look into that. So biologically, we can generate a sense of calmness through the soothing rhythm for the breathing, and we might be engaging people in work on their body to feel a sense of safety with that. And I guess, you know, some of those things that I mentioned earlier on about grounding techniques and things like that, some of those things are very transferable into working with people with hearing voices. Okay, so understanding people's life story, how those threat responses came to be, really important issue, and how those things get played out in terms of dealing with voices. So I'll just move on a little bit there. In terms of the way that we work with self-compassion, there's lots of things which you'd be, those people who've worked with CFT before, so compassionate letter writing, chair work, those sort of things can be really positive things to experience. Okay, all right, so repeatedly practicing these things brings out that sense of safeness. Okay, just trying to rejoin the meeting on my phone here just now so that I can see you again. Right. Okay. So yeah, I'm basically cultivating that sense of self-reassurance and things like that. Okay, it's all about developing safeness and connection, really, that we're looking for, learning how we can do that. There's a lot of psychoeducation that can go into CFT, so understanding how these brains evolved to do what they're doing. Okay, I do touch on shared formulation later on in the slides, but I probably won't have time to go through that in much depth. What we're keen to do is to make sense of the safety behaviours that are going on. We're very much into validation, of course, people's experience, and where it's possible to identify if there is an inner critic, an inner bully. Common to CFT is that sense of it's not your fault that you were born into this world, that you've experienced these early things in your life. You have responsibility for attempting to alleviate the suffering, but you aren't in yourself responsible for those things early on in life. So that's a kind of an important premise of CFT. And we want to do a lot of work through the therapeutic relationship, where possible using imagery or an attentional focus, which could be mindfulness, but it could all be other things which help people to orientate towards a better self identity. Okay. So in terms of the next slide, right, okay, I've got the right meeting now. That's good. So why CFT? Well, it is an integrative process, brings together lots of different issues, and it works at relational depth and also experiential depth. I've mentioned that earlier on. So we certainly are concerned with the person's relationship to their experiences. All right. And as you can see, the definition of compassion being moved by suffering and motivated to alleviate that. Okay. All right. That's we often sort of see the shadow side. Okay. Now, I was just going to mention that safeness here, that isn't something which is a given for everybody in the therapeutic relationship. Sometimes when we provide safety, that can still leave people feeling in the bubble of therapy, maybe, that they've got a good thing going, but outside it's still unsafe. So safety can still be linked to threat. I'm safe here, but threats outside, or whatever it might be. So safeness is a really crucial issue to develop in the therapeutic relationship. Okay. And that, of course, can be very much linked to people's earlier attachments, and indeed how they're attaching in the therapeutic process, and to the teams that we work within. People will be very familiar with this, I think. But another premise, second premise really of CFT, is that we've got tricky brain design that unfortunately our reptilian ancestors, that the alarm system that they've got built in, hardwired in, that means that it can be very difficult. Sometimes people can ruminate, they can worry, and it can be hard for people to be in the present. And one of the reasons why Paul Gilbert developed the therapy was that he had the insight that cognitive challenge is unlikely to be effective when people are feeling under a great deal of threat. Okay, so I'll just kind of touch on formulation a little bit there. That, yeah, the idea is to collaborate in that model. Okay, and that's where we bring together the psychoeducation that we've been doing earlier on. It can be quite there's a lot of stuff to front load in CFT, and a key aspect of this is really to understand the function of the voices, to be able to bring compassion to the voices. Okay, so that's a very standard CFT formulation, and we would generally be using something like that for working with people with voices, but just to highlight the function of voices. On this slide here, we're looking at the protective function of the voices. How are they actually working to protect us from harm? And that might, in the early stages, be something which people can't get their heads around, because they find that well, this voice is attacking me. This voice is telling me to do awful things, and the function there can be something which needs to be developed. So there is a lovely video there to do with thinking about the function of a voice, and you've got some questions there. Okay, so here's one that's worked out. Somebody that I did what we call a 4-session formulation and consultation approach. So I was able to work quite quickly with a woman who had heard voices of her neighbours who were saying some terrible, terrible things about her and what she should do. And she was screaming at the top of her voice almost continuously, which led to a hospital admission and so on and so forth. And it was really helpful for her. She kind of started to understand how a lot of what was going on with the voices was related to some of her key fears. And as you can read that through, you can start to see how those things relate to the self. Okay, So very simplistically, I put some ideas, could have made, different circles, different sizes and things like that. But this is what we were working with in that 4-session model. Okay. So in terms of skills and interventions, that's in CFT, you might think of the 3 rings really. That there's the skills training bit, and then we're also trying to encourage these attributes. Okay, and around all this work, there's the warmth of the therapeutic relationship to promote the person being more comfortable with experiencing compassion. Okay. Again, in the PowerPoint, you'll see that there's even more videos there, including the one that I couldn't really get on screen there properly. It's clearly something I'm missing out on with PowerPoint there. So you can look at those at your leisure. All right, quite short videos. All right, so, and this one, engaging with voices as well. I mean, that's really, really helpful to get a sense of how people can develop that compassionate relationship. So I'm just going to say that in that little cartoon that I nearly showed, it's only 6 minutes long, but it can be a really useful one to watch with a service user, a bit like with ACT passengers on the bus, that you can kind of see the 3 circles on the character's chest, and you can see when different aspects are getting sort of stimulated. Yeah, and so it's not saying that CFT is something which can instantly bring about change. It takes practice. Okay, a bit like a marathon runner. We're encouraging people to practice different skills for different situations, and use them whenever it's needed, really. Okay, so I've touched on the so CFT is a biopsychosocial approach, and I've touched on some of the biological aspects. I suppose when we're thinking about the development of compassionate feelings and so forth, we're sometimes a bit like happens in CBT, that we might be encouraging somebody to, what would a friend say, what would a relative say that you value. So we're also looking at how the person can develop their compassionate self. So in that, we almost like create a safe haven, a secure base in attachment terminology, to help people to experience all the skills, the attributes that you just saw in the colourful slide a few minutes ago, and really all the things that are needed. Sometimes we invoke the perfect nurturer. So sometimes there are, people have had such terrible experiences that they also need a chance to develop something positive, and they may draw on a number of different areas, maybe religious imagery, or it might be somebody they really admire, a celebrity, or whoever, from wherever it might be. I've had people making up a composite of like animal and human parts. Even there's one of Voice Heroes that I worked with quite a lot in Long Eaton. He used a tree. That we can have compassionate, non-human, non-mammalian sort of figures. So, okay. So there is that. And I mean, probably just reading this off the screen, that psychoeducation, can be really important to help to foster that compassionate self. And motivational interviewing can be a really important early technique to help with de-shaming and noticing how we get these dominant subordinate kinds of situations that are developing. Okay, so mindfulness is something which we do see as kind of implicit really within CFT. people might come at it from a soothing rhythm breathing, or they may come at it from other places, but it's helping people to not get lost in their experiences, but to have clear awareness. Okay, and I just need to keep a close eye on the time at 22. Okay, that's good. So externalizing the self-attacking. So again, the message, not the person's fault. What we're looking at there is to help people to understand how the voice is doing this, and may use phrases like this. Sounds like you've got a part of yourself that's very attacking. So it's very compatible for those people who've worked with dissociative identity disorder. That I think there's a lot of areas that you can draw on from parts work. Okay, so that's quite a positive thing. I would say as well that the chair work is quite a distinctive feature. I mean, obviously it kind of originated in other therapies like Gestalt therapy. Having a compassionate chair where the person can sit in that and develop that compassionate self can be very, very positive. And then adding to that, you might add a chair which represents angry self, sad self, different parts of the self, or you might have them embodied by voices. Okay, so another thing there, I mean, we've got a cute grandma figure here. It might be that you invoke an other person who is the carer, bringing the caring mentality. Okay, so you can read this off the screen, I guess. So interviewing the critical voice. So this could be done with the chair work. That what do you hope to achieve through the bullying, etc. Those sorts of things. So I found this a really interesting kind of approach, and it's so often it comes up that the one who's the voice that's doing the bullying. Paul Gilbert talks about the way in which it's a bit like the Wizard of Oz. So when you peek behind the curtain, you see this man who's orchestrating everything, and it kind of takes away some of the power, really, when it becomes possible to find out what the protective function was of the voice. Okay. But we do need to work safely. So again, working in the area of trauma, the window of tolerance is important. Stress vulnerability model as well is sort of similar-ish sort of area. Focusing on the here and now. Okay. Right. And the role of therapeutic relationship. Within this, we need to think about our own threat system and how we manage that in the therapeutic relationship. Again, the idea of physician heal thyself comes back to it. Okay, what might you be bringing in? When might it be activated? So essentially, those people who are from the psychodynamic persuasion, that you might be thinking about the total transference here at times, like all the different things that are brought in, and trying to separate out what we can offer and maintaining that mindful approach within that. Okay. Some of the complexities, we don't have a huge amount of touch on this just now, but I guess medication can flatten people's experiences sometimes, and it's really important to maybe titrate the dosage a bit to if somebody is very much blocked in terms of their emotions, but recognizing as well that we don't want to encourage people to go against medical advice. It's really important that people are on the sort of the most effective dose, really, that they can. But there may be defenses against feelings of closeness and things like that. Neurodivergence, I'd like to have talked a lot more about this, really, but that certainly affects people's stress levels, and we can draw on people's strengths and needs, can have quite an impact on personally relating. So, I guess, endings is a really important thing to address in all therapies, of course. I think particularly with psychosis, where people have had a first episode or a second episode, that as time goes on, that the impacts can be like a sort of, people can lose a sense of themselves at times. And it can also be very difficult for people to have a good experience of grief, if you like. So those things can be key. Some of the things that are in the PowerPoint, I mentioned about some of the scales, like fear of compassion and things like that. There's a lot of different ones which are really useful to draw on. And these are some interesting articles that we've got. Okay. And I guess this one I'd highly recommend, relating to voices. I mean, I've got some of these books just next to me here, actually, but Charlie Herrick-Maitland and Ellen Longden, I mean, they're really key figures in this world, besides Paul Gilbert and others that I've touched on today. So, yeah, I mean, please, follow these things up if you've got an interest. And I'd say the TED Talk by Eleanor is fantastic, actually. Those people who've not seen it, I mean, that's well worth watching. Okay, so I've got references there and so forth. So there's all of that. But I don't know whether, I think I might stop sharing just now, but just sort of bring us back to the room. Okay, so now, are there any questions? Are there any particular comments or anything that people would like to go back over? Have we got in the room? Okay. All right. So I've reached the end of the slideshow just now. And you can hear me okay? All right. So I suppose I was just thinking about applying CFT to voices that I think some of you might have missed the very start, where I suppose I'm thinking about voice hearing being a very normal experience. And looking back now in my career, I've thinking that the everyday aspect to trauma is something that I think for us in our services, very relevant to what we understand about voice hearing. And yeah, just sort of curious about what people's views are about integrating this into other work that they're experiencing. Okay. Any comments? Just throwing it out there.
I was just thinking a little bit, Paul, about so I'm trialing right at the beginning of using CFT with someone who doesn't hear kind of hears voices, but just hears when he's away from home, hears his partner talking to him, but she's not there. So very obviously, because it's arms, so it's very kind of low level. And I was just thinking about there's lots of stuff in terms of, like you said, like an underdeveloped SOO system and an overactive kind of threat system, and a lot of that has been managed, I guess, by developing kind of a very aggressive kind of persona, a very sort of hard persona. So I guess it's so I was just thinking about, because I haven't quite made sense of that experience yet. It's not hearing, I guess because it's not got to the point yet where maybe the voices have developed into something more kind of problematic. But I don't know, I guess just a reflection of, like, just I see some very interesting kind of low level unusual experiences that haven't quite developed yet into that sort of something really quite like fairly distressing for him, but not sort of overly kind of critical, or sometimes a bit harder to make sense of in some ways. It's not really obvious.
I know, absolutely. Well, the thing is with the voices that they can be allies, and having the voice of your partner present when you're struggling can be so valuable. Ron Coleman, he helped us to develop Hearing Voices Network in Derbyshire. He's quite a forthright figure if anybody's come across him, and he talked about how he would use his voices to help him when he was playing chess against some of the acute ward staff, and he'd find that he was able to use use his voices to beat them every time. So there's there are different ways that we can work with voices, and again, it's that thing about getting into more of an understanding rather than a conflicted place with voices.
Yeah, I think actually for him, the sense he's kind of made of it is that he was working a lot and he was away from home, and actually what he wanted was to be home with his family, but he felt quite conflicted because he had to go to work to kind of to provide for his family. So but I guess it's just interesting seeing the, you know, that kind of the lower level kind of unusual experiences that I'm sure quite a lot of people probably have, but never, as you say, like a lot of people never present services, do they, either because the voices are kind of neutral or actually they're quite helpful. Yeah.
Totally, yeah, absolutely, yeah. I mean, we're in secondary care services, I suppose. Yeah, I appreciate your role there in ARMS, and in secondary care services, there's such a lot of shame that's accumulated for people, and I suppose I was just trying to draw on that, really, that many people have experienced rejection or marginalisation or even persecution, and so there's often that malevolent kind of intent to the voices, which makes it difficult when it's like an external focus to the shame, but also that can impact on the sense of self being unattractive, and that can carry a lot of evaluations into the sense of self. So it's not just a failure to reach a standard, which you can find in depression and so forth, but it's also, very much an undesired self which has come to the fore. And you can see a lot of gender differences in how voices get played out. And I find it really fascinating how even when an abusive figure has been female, that very often the dominant voice is actually male, and it often represents more societal kind of issues and things like that. So there's all sorts of things that can impact on the hostile dominance experience. Yeah. Ian.
Thank you, Paul, for the presentation. I think it's just sort of reflecting on what you were saying there, as sort of changing the relationship to the voices. I think often we think about the interventions of working with trying to prevent, as in the armed service and early intervention, catching the first episode, but we have a large population in secondary care services that have had psychosis or psychotic experiences for decades. And I think CFT can really provide a really powerful tool of de-shaming, learning to adjust to living with a long-term condition and changing relationships with voices. Absolutely. And I have a patient at the moment that uses his voice helps him with his worries during his worry period to help him solve the problems for the day, and helps determine whether it's a hypothetical problem or a problem that needs to be dealt with. And I think it's the CFT approach has served a really valuable purpose in almost influencing other psychological therapy approaches, but also being a standalone psychological approach in itself, in utilizing that three system formulaic approach, which has clearly got some really strong sort of research supporting it, both at a biological, psychological perspective. So yeah, I think it's also nice to think about how we can apply these approaches within patients that have chronic psychosis. I think sometimes it's an underrepresented area for research and for our energies and efforts. It's almost like the treatment of choice is medication, and they get lost in the wilderness.
That's very true.
But CFT has a lot to offer.
Yeah.
So thank you.
Yeah. No, absolutely. So it's trying to sort of work sometimes with the so-called negative symptoms or negative signs of schizophrenia. Sometimes, but kind of helping people to experience emotion sometimes can be, really kind of challenging thing for people at times. And I think it's something else that you mentioned there. That it's really interesting having you, Charlotte, working in ARMS, doing that preventative work, because that's so valuable, and and such a lot of neurodivergences there in the EI cases that we see in Derby, and kind of understanding how that all gets blended and played out and things like that's really, really key. So yeah, I mean, we certainly see that dissociation has quite a mediating effect on the experience of psychosis. And I would also say CFT, implicit within that is the idea of multiple self. So that's why I'm saying it's kind of quite compatible with working with presentations like DID and things like that. Well, look, I completely talked there with the video. I thought that would work really sweetly, but I'm so sorry about that. But I really appreciate your time, and I hope that you'd be able to make use of the presentation with all those links in it that I put in the chat. So are there any other comments that anybody would like to make at this stage? I appreciate people have to go, and I won't say goodbye to everybody. I can only see 6 of you at a time, actually. So
just to say thank you, Paul, I think.
Thank you so much. Okay, really appreciate your time. Yeah. Okay. All right. So, well, should we call it to a close there then? You get a couple of minutes before your next meeting. We need to make sure we look after ourselves with that. So thank you all for coming. I really appreciate it. Okay. Cheers.
See you
Bye for now.
later. Bye.
Cheers. Thanks again. Cheers. Bye.